Welcome everybody to our webinar after such a long time. And as usual, our dear Dr. Chris Prue is going to run this webinar. I'm going to leave the floor to him in order not to delay you any further. Go ahead, Chris.
Thank you, Dr. Rana. So, yeah, super cool to be back and after all this time because we really enjoyed this and getting back to business here. So many of you have already noticed if you're returning visitors and have been using the system. So myself and my best friend here, Rana, will continue to do these. And gosh, I know a lot of you, so it's cool to see many of you return and from all over, from the UK, South Africa, Czech Republic, Spain, United States, and others. So I'm just going to get going. So this is what we refer to as a recurring webinar. And so it's movement analysis with key pathology. So what we do is we take a use case and we use that as an example to basically go through the system or various aspects of the analysis. So we do not get into how to take an analysis or anything like that, but it is, sort of specific to the interface that we use at the Baliston Health Mov-Scan device. That's what the new name will be. We were using Mov-Scan before, but now it's under Baliston Health Mov-Scan. And so utilizing that particular tool to evaluate various types of conditions, abnormalities, things that impact movement. And so this month, we're going to be focusing on peripheral neuropathy. And I am going to share my screen because, as usual, I made some slides. And I don't know. I say I don't do that. I won't do that, but I did. And so here we go. Mostly just to, provide a little bit of context and get into some of this. And this is, again, this is one of my cases. And I'm not treating this person with respect in the same way that the person who's managing this pathophysiological process per se, which some of you probably actually do, especially on the neuropathy side. I'm more dealing with the movement aspects of things, and so with this topic, and in fact, one of the reasons that it was of particular interest to me is I've been working on a new program. And it's a certification in managing peripheral neuropathy with emphasis on diabetic neuropathy. So there are multiple reasons that someone can experience a peripheral neuropathy, but the peripheral neuropathy in general refers to some sort of, dysfunctional capacity within the neurological system, in particular, the peripheral nervous system, and it can deal with motor, sensory, and even autonomic, and it can even deal with all of those things eventually, which is why we see some of these conditions that produce it can be super bad. So as you can imagine, anything that is impacted by a motor, sensory, even the autonomic nervous system can be influenced. And a lot of us will think of that more so in like movement aspects and sensory, especially dealing with pain, weakness, abnormalities in motor unit recruitment while conducting certain types of movement patterns. And so again, there are multiple factors associated with that, but the pathogenesis is somewhat similar. In other words, it's a damage
Chris,
to. Yes.
I'm sorry to cut you in, but I think you're not showing us the screen we want to see. It's not the presentation. I can see only like a Wikipedia page. So is that what you intend to show us?
No.
Okay.
That's yeah. Oh, I see. Let me see if I can stop sharing that and go
Yes, and
to
you go back.
here. Do. There's the matrix.
Yes, now we can see your presentation.
Does that make more sense? Yeah, so this is the start, and then I was just talking about the pathophysiological process as it's related to peripheral nerves. But so the pathogenesis of it is really destruction of the axon and the myelin sheath if it is a myelinated type of nerve. And of course, that's going to impact its conduction, right? So in healthy myelinated, right, we have that's what's referred to as that saltatory conduction, and it skips from node to node, and it helps transmit that information down the axonal pathway. And so various pathophysiological processes can sort of damage that. And in particular, as we're about to talk about, is going to be sort of this metabolic problem, that there's also some overlap into this ischemia or vascular compromise. But there are other types of conditions that I'll show you here in a second, such as chemotherapy or neuropraxic, axonotomesis, neuronotomesis events that compromise influence to the nerve. And that could be as a direct pathway from the vascular system. It could be compromised to the nerve itself. So remember that, a nerve, we always think of that as sort of that electrical transmission, but there's fluid inside of it. So there's an axoplasm, right? So there's a fluid constituency inside that, and when we compress that, it influences the flow of that, which is essentially how we provide health nutrient to the nerve. So the implications, especially when we're dealing with a lot of these movement conditions, is it disrupts that balance between the sensory and that motor response. And so obviously, if it was sensory, you can't feel things, and that feedback is not going to be able to be provided to create coordinated movement patterns. And so think about proprioception and the ability to know like where a joint is in space, even when we're not looking at something. And so, for example, in that poor feedback, and I remember back to graduate school, and in my pathophysiology course, and my professor would always use examples, and it was a very poor community, and there was just a couple of stores, grocery stores and department stores that everybody in the area would shop at. So you kind of, got to know people or see the same people over and over again. And so we got into this specific topic of peripheral neuropathy and the sensory impact and its influence even on the motor response. And, we talk about this one particular person that, because they had really no sensation left in their lower extremities, they would walk on the medial aspect of the medial malleolus, right? The inside of the ankle bone would actually touch all the way to the floor, right? Because they didn't have that sensory impact, and then eventually, leading to wounds and things like that. But from sort of our example of a gait impact is that inability, to know where their foot is in space, and then certainly the motor aspect and showing those relative weaknesses that we'll talk about a little bit more. And then, of course, in the autonomic involvement and dysregulation of even the vascular tone, which is obviously extremely important. And then it connects to, as we see, we're specifically referring to the neuropathy here, but all the other metabolic consequences that occur as a result of some of these conditions where there is an increase in oxidative stress. So this is just, a list of potential conditions that we think of that can lead to peripheral neuropathy. So I put diabetes mellitus up here at the top. And I was actually just listening to an interesting podcast and thinking about the classification of diabetes. And so and how this researcher was considering that diabetes insulin dependent and diabetes non-insulin dependent are really not the same condition, and the only thing that they really share is insulin or its impact on the disease process. So they're actually quite different, or the outcome, right? So increased in blood glucose, and so that hyper um, glycemia effect just leads to a whole lot of these metabolic cascades, and eventually results in sort of this oxidative stress that eventually causes death to tissue, in particular, such as the peripheral nerves. So there's this, I call it a double whammy, right? So there's the impact directly on the nerve itself, but we don't even think about, what that impact sort of secondary, or it's actually even primary, which is to the vascular system. And so hyperglycemia is also related to, like I said, oxidative stress and inflammatory conditions. And so that can have that double whammy, sort of impact on what's going on. And leads me back again to why are we focusing on peripheral neuropathy related to diabetes? Well, it's the most common cause here in the United States. And it's this cascade effect because it's associated with metabolic disorders, heart disease, cancer, and then we can also sort of think about, following down this pathway, that it's also the peripheral neuropathy that's associated with the diabetes mellitus is then related to wounds, and then wounds is then related to amputations. So it's the number one cause of amputations here in the United States. And then the other reasons for amputations typically is, potentially infection, or, automobile accidents, motorcycle accidents. In fact, I've got a case coming up that hopefully we'll talk about in the future, where someone was involved in an accident and it affected their lower limb. But so that's kind of the reasoning for this, because it has such a broad impact, and we can probably do something about that. So chemotherapy, it's just the destruction as a result of taking in, and we could even combine that with the radiation-induced therapy, because a lot of those people might be getting both of those, or actually for the same reason. And then certainly some types of deficiencies that minimize the appropriate nutrient intake and actually create more of a problem, even in that oxidative stress, right? Because of the influence that it has on overall metabolism. And then autoimmune and hereditary disorders; those are just conditions that obviously have an impact in certain mechanisms associated with the causative factors when it comes to the destruction of those particular nerves. And so specifically in the diabetic neuropathy, we're typically dealing with the extremities, right? Because it's associated, sort of the further away that you get from the heart, and that's actually associated with the length of the nerve fibers themselves, especially when we look at the legs. So it can initially start as sort of that metabolic stress as a result of the hyperglycemia, and certainly some other things that the mechanisms are not just directly associated with being diabetic, but it's the insulin resistance as well, and we can talk about that at another time when we look at that. But in any event, so there's going to be degradation to the microvasculature, which also results in degradation to the nerves themselves, and so they're not getting the appropriate, basically, nutrient introduction to be able to be metabolically viable. And that's where we tend to see that necrosis, because we don't have the ability to generate ATP or chemical energy appropriately. And if you think about some of the treatments for that, and why we would care about that, again, leading to things like wounds, which subsequently lead to infections, and then eventually, resultant amputation. So specifically with gait characteristics, and this is something that we've been working on. Actually, our colleagues here at the company presented a paper a few years ago, in being able to use our system to evaluate diabetics and do the comparison between a control group, the group that actually has diagnostics in neuropathy, and then the group that does have diabetes, but they're not diagnosed with neuropathy. And we're able to identify that even before people have neuropathy, there's some changes in their gait patterns. And actually, there's another study I talk about here real briefly. So we see changes in ground reaction forces. They tend to be higher. They have weakening of the musculature, and as you can imagine, and we're going to kind of go through this when we go through the system. But basically, they take on a very similar gait pattern as like an older adult with weakness and is at risk of falling. And in fact, this is a big reason why there is that risk stratification in falls when it comes to measuring people here in the United States in particular. And because we see an increase in hip and knee flexion, that's also when we look at the spatial orientation of how high they take their steps. It's a process, and so there's going to be some changes, and then other things are not necessarily going to change just yet. What's interesting is we consistently also see uh, ankle range of motion. So in dorsiflexion and plantar flexion begins to change. And we used to sort of think about that as they weren't picking their feet up. Well, it's actually not just because they're taking shorter steps or shorter strides, which also we see. We also see um, slower speeds, and initially there's a potential higher cadence, and then that actually slows down. And again, we're going to talk about this here in a second, but there's actual implications. They don't have as good of ankle dorsiflexion and plantar flexion, and so that has an impact on how they can step, and obviously that's going to even further secondary impact their step or their stride length because of that, and not just because they're trying not to go, a little bit faster. And so that's actually seen. If you look at this bottom one here by Yabusa et al. In 2006, they were just measuring. Their marker was glycosylated hemoglobin, HbA1c, and just showing that marker is statistically significant and related to some of these latencies that we see within that motor unit recruitment. So I'm going to go to the analysis here, or your home page. Over here on the right is your patients, your equipment, your settings, and your support. So if I click on the equipment, it's going to tell me what sensors I have associated with my particular system, because remember that you can actually add more. Oh, I have them right here. You could add other sets of sensors to your system. Settings, I'm in the United States, so we're going to use English, and then the unit system that we use is still the Imperial system, of course. Um, you can share workspaces and things like that. So let me go back up to here. I'm going to click on patients. I gotta move my picture. And so you can choose your patient. Now, when you choose your patient, remember that, again, there's another dashboard specifically for each patient, and it highlights the last 5 conditions under the latest activities. There's a patient file with all that information, and so you can actually set this up in advance, so you can have this before a patient comes in, and it shortens the amount of time that it might take to conduct an analysis. Practitioner analysis will show you all of them, and then evolution we'll come back to here in a moment. So I'm going to go back to the dashboard, and I'm going to choose this particular activity. Remember also that even within the analysis itself, the report, you can also put in some notes. So you'll notice I can put in pain profile, walking aids, shoes. She does occasionally walk with a cane. So this test was done without the use of the cane, and it was overground walking. So it was not on a treadmill. If you've seen me in the past, sometimes I do some things in a treadmill. Actually, I'm going to show you another one here in a moment that will be done on a treadmill, and I'll explain why I might do that or choose to do that. You can also put in the shoes. I always recommend that you put in the shoes, so that way the person comes back and wears the same shoes every time that they're tested. And that's important because as we've shown in previous um, webinars, that your footwear impacts the way that your feet actually come in ground contact, which obviously affects, the entire chain as a result of that. So that's cool because footwear can actually be used as corrective devices themselves, and we may do this with some of these particular people. So remember that we use a color orientation as part of the readout to make it faster and easier. So as you get good at evaluating these, kind of like if you've, learned how to read X-rays or blood reports or EKGs or EEGs, we're looking for the things that really stand out, and we get used to what's normal. So if it's in amber, that means it's sort of in the middle. So if it's green, it means it's one or less standard deviations away from the normative values that we have with that particular patient. And what we mean by that is we didn't make this up. This is from the literature, the normative values of a patient's spatial temporal parameters, as well as these biomarkers with regards to their movement, relative to their age, their height, their weight, and their gender. So that's why it's important to put those characteristics in appropriately, including the size of the footwear that they're wearing, because that's also used in the calculations. So if it's green, it's less than one standard deviation. If it's amber, it's between 1 and 2 standard deviations. And if it's red, it means it's beyond that. So if it's amber, it causes me to maybe take a second look to make sure. And you'll see that it's amber, and it will go to amber up to 90%. And it can even go a little bit larger than that if it's an older adult person, because we have larger standard deviations. The cadence, it's showing that it's in the red as well as the speed. And so it gives you this information down below to show you those normative values, right? So in the cadence, now remember that cadence and speed are directly related. And so speed is going to be a product, right, of the time that you spend in a stride or a step, and the number of steps that you take, right, over a time period is going to be your cadence, right? So relative to this person, they should be somewhere at 106 to 126. That would produce also 2.2 to 3 miles per hour. And that's where that comes from, because one is definitely going to have an impact on the other. But think about that for a second, where people could have a higher cadence. So imagine this was 130, right? But yet they were within the normal speed. And the reason for that might be because they're making up for a shorter stride or step length. Okay. And so that's why, understanding the relationship between these two is actually a good thing. So here's the basic spatial temporal parameters. So we're looking at the left is going to be in the top, and then the right down here is going to be in the bottom. And you'll notice the red here. So it's telling us that that's an abnormally low stride length. And look at the stance and the swing time. So typically we're 60-40, right? We're 60% in the stance and we're 40% in the swing phase. And so we got about a 5% deviation in there, but we're up to 70 with this particular person. But it's not just that, right? Because theoretically, if this person had a slightly higher cadence, they might actually have a normal percentage with regards to that particular walking profile, right? And so that's why it's still important to take this into consideration. And what we can do is we can click on the advanced. And if I bring this down, now it breaks it up a little bit further. So again, using the same color profile to let us know, if it's normal, kind of not normal, and outside the range. But what's unique with this system is it tells me whether it's on the high end or the low end. So you don't have to memorize those particular factors. So we look at the stride duration, and the stride duration is really long relative to the distance that she's covering. So it accounts for the fact that she's taking a lot of time to do that. And again, we see that because there's a reduction in speed in people. And by the way, this patient does have peripheral neuropathy. So we do see a very long stride duration. Okay. Now let's go back up here. And one of the reasons is because there's a really, really long stance phase, the relative percentages. And that is going to be correlated here, that the actual stance time based on her ground contact time relative to that overall duration of stride length and her cadence is, again, it's still exceedingly long. And we do tend to see that in patients that have um, diabetes and peripheral neuropathy. Why is that a problem? Well, because one of the things we take under consideration is the forces during that. And I told you, when I'm showing you the slides, that there is an increase in impact force. So there's not only an increase in impact force, but there's also going to be an increase in duration that this person is in contact. And so further creating some of that compression. The reason we are concerned with that is the implication that it might have to do with wounds. And there are some other factors obviously associated with that, such as the shear forces, as well as changes in temperature in that particular area. And again, we also see that the stride length is again extremely low for that particular person. So this is how you can get in a little bit deeper into those spatial temporal parameters. So if we look at the gait line, so the gait line is the center of pressure as we're going through the stance phase. So this is, it's not a pressure sensor, as most of you know, but we're using an algorithm that is associated with a pressure sensor relative to the foot position. And so the application is correlated to that. So here's what we want to look at that's kind of interesting is looking at this percentage. And so there are normative values with regards to how much time you should spend in each one of these phases. And we see that, the heel strike it's pretty close to normal, but I'll show you something here in a second and why that is. And then they stand in this foot flat position for an extended period of time, and then propulsion is pretty short. And that's also consistent with what we see in diabetics, especially diabetics with peripheral neuropathy, is there's a reduction in propulsion. And that could be associated with the propulsion rate. But we look over here and her propulsion rate is actually pretty normal. But there's an explanation to that I'm going to show you here in a moment. And so that's why, understanding these particular concepts is important, because, don't just assume, oh, her propulsion rate is normal. So her propulsion rate, this is calculated, it's a ratio based on the velocity of that toe off position between the hip flexors and the plantar flexors. And so I'm going to show you one here in a second that's very different. So relatively speaking, she seems to be engaging both of those, which is a little unusual. What we tend to see in older adults is they don't tend to engage their hip flexors very much. Low back pain, weaknesses, core stability, and things like that. But she seems to be doing that. But again, let me show you, why that is here in a second. But before we do that, we're going to look at the pronation and supination angles. So this is also kind of important, because when we looked at the gait line, we saw that she has some slight increase in pronation. It's worse on the right side than it is on the left. And then you look at her toe off position, and she's definitely deviating in the opposite direction on that left side. And we see she's overcompensating for that on the right side. So this is often associated with just, her relative position that we see in there. But I might take this into consideration because I might use an orthotic if I wanted to actually correct this. And that might also correct some of these other deviations or these time courses that are changed as a result of her gait pattern. Also, relative to balance, right? And so doing a balance test on this particular person, it did not go very well. So she's very concerned about falling, which is one of the reasons why she also walks so slow. And again, one of the characteristics associated with peripheral neuropathy in the diabetic patient is loss of balance. And part of that is because of the strength, because of the endurance, especially if you're going to have them walk any great distances, but literally changes in um, their ability in proprioception and vestibular. And so lots of, again, overlapping things, which is why people with diabetic neuropathy, that's one of the boxes that we check when we look at risk factors with regards to fall. So a couple things to notice here. So let's look at the foot progression angle. So the foot progression, oops, I need to go back here because I didn't explain this, and I'm used to talking to people that might know exactly what this is. So this green corridor, that is considered to be the normative trajectory, right? And again, keep in mind that this is a foot inside of a shoe. So it's a combination of a model. In particular, think about like a block model where we are using a component of pronation, supination with eversion, inversion, but looking at the trajectory or the foot pathway through that ground contact time. And so that green is that normative pathway. You can put your cursor over these dots at each one of these moments, right? So this is heel strike and then toe down into the foot flat position, and then heel lift, and then eventually toe off. So that gives you the actual numerical value, which is going to be relative to parallel to the Earth's surface or the ground. And then it gives you a min and a max. That's actually standard deviation. So it gives you some variability in there. And you'll notice that, here there's very little variability. But as we get up here, there's a lot more variability. So she's not as consistent when she goes into that toe off position. So what I'd like to see is a little bit of variability. So this is actually pretty normal. You see a nice parallel pathway of these lines. So this tells me that this person is very consistent in this area. It's in her toe off position that she doesn't seem to be. And again, that's also consistent with what we were talking about earlier, is that propulsion is going to be affected or toe off because of typically strength. So at least at this phase, she's also engaging her hip flexors to go into that propulsion because it showed that they were in really good ratio. But what you do see is there's a decrease in that particular time course. So that tells me that it's not very strong, most likely. And again, because she's taking relatively short steps or strides with a really low duration with regards to that particular toe off. Sort of related to that is going to be the foot progression angle. So we look at asymptomatic people within two standard deviations is typically between about -2 to +12 degrees. So slight breaking the midline to going to the outside a little bit. So she's way beyond, especially on that right foot. And we see that that's one of the reasons that, she lands with the heel. So that foot is going to be abducted, and that causes her to rotate. So she doesn't really have good trajectory or position for that foot to be able to have a really good toe off or get back into classic, supination with regards to that toe off position. Pretty normal with regards to circumduction, but again, she's not really moving that much. And so if they don't have, as we talked about earlier, good plantar flexion and dorsiflexion, then they're not going to be able to lift their feet if they're really weak in the hip flexors. And so they just kind of scuff along, right? And so we do see that here where we have very low angles on toe off, which again, it builds my assumption of what's going on with this person. Obviously, I saw this person, so I know this anyway. But looking at the really short propulsion phase during toe off, the abnormalities with her position doesn't make a really good, strong, toe off position. And then we see that she has really reduced angles. And again, all of that leads to that. Okay, so she's not doing a really good job here. One of the reasons why she also has a shorter step or stride length. and might give you some implications as to some of the things that you're going to do about it. We see close to sort of a normal, heel strike. And so one of the things that we do see as a result of that, remember that these people tend to have an increase in hip flexion. And I didn't even allude to the little video that I had on that last slide, where they tend to take a little bit of a hunched over position. And it's typically compensatory as well as being associated with weakness. And again, you can add comments here. I'm going to show a different patient here in a moment, but if you click on evolution, evolution allows me to see all of the tests I've done. I have 4 different systems, and so sometimes I test people on the wrong app, and so I have to kind of do it manually. But what that does is the evolution allows me to see all of the tests that I've done on a particular person. So I can see some of the changes, or if we're looking, maybe not for progress, but we're looking for regression over time, then that would potentially be a little bit problematic. I want to go to another patient here real quick. And the reason is, this is a little bit different. I'm not going to give you all of the information because I think I'm going to be using this for next month. So you might want to tune back in and see kind of what's, potentially going on with this particular person. But I will tell you that diabetic, and at this moment in time, just not very well managed. He's a type 2 and a type 1 diabetic, and difficulty, taking on body mass, and, managing his insulin has been very, very challenging. He has some other things going on too that I'm not going to tell you just yet, but just to again highlight, we see that cadence is really low and the speed is really low. Now, this one I did on a treadmill. The reason is because I want to control for a follow-up, and with a treadmill, obviously I can control the speed. So what I typically do is I start off slow and I increase the speed up to a point where patients feel that it's comfortable. And then I may stop it and then start the test. So I may do a little practice before we actually initiate the test. So I knew that this was about their comfort speed because they just weren't feeling overly stable. And again, there are some other factors that make this a little bit more interesting. But so obviously walking is very, very slow. So this person is about 1.75 meters or so. So they're definitely taller, and so their speed should be much better than 1.3. But like I said, it had more to do with balance, and some of it is biomechanical. Some of it is the influence that uncontrolled blood glucose levels, long-standing, actually have. And it was so long-standing, he's had a lot of other conditions as a result of that, which I think I'm gonna talk about that next month. But if not, it'll definitely be in the future. So if we look at his advanced profile, as you can imagine, the stride duration is very long relative to a short step length, and that his stance time is also overly long. Horrible balance, not very good balance at all. We see that, again, there's a reduction in this propulsion, and really, pronated, or a lot of pressure is going on the inside. And what we see over here on the propulsion rate is mostly all hip flexors. And there's a particular reason that is going to be explained next time, but let's just say that he has no choice but to use his hip flexors in this particular case. All right. And this, again, it actually is uniquely highlighting how the system is able to capture that. And then we'll go into the details here and look at his profile here. So as you could imagine, based on the gait line, that he's very much in an overly pronated position, and we see that even his trajectory with regards to circumduction He's not really good at getting really any leg swing, especially on that right side. In fact, he tends to break that midline. And we see that he has really high propulsion angles, and that's actually in an effort to get more knee flexion so he can hip flex and actually clear that ground. Okay. And so when we look at his heel strike position, it's also relatively low. So what could be interesting is, and this is something that is new, and I'm not going to cover this a whole lot. I've talked about this in the past, but we have something unique that we're going to be talking about in the very near future. So I could theoretically correct, his ground contact position with some orthotics, and that can also help with his balance. It can help with, normalizing his gait. So there's some interesting things to look at and say, what do we work on, and it's kind of, if we attack it, if we try to get at things from multiple angles. So I look at like footwear and orthotics as it's part of the treatment, just like I give exercises. It may be for a long duration, it could be for a short duration. And here's why. If I can do something externally to help support a more normal gait pattern, he can walk more, he can do some of his other exercises and things like that. And so that can assist in allowing us to be a little bit more progressive. So key takeaways, think about diabetic anyway has abnormal gait patterns. And so we can use movement to say they're either approaching that peripheral neuropathy problem or we're getting better and they're staying away from that peripheral neuropathy problem. Because once they start going down that pathway of peripheral neuropathy, then we're concerned about some other things, like I said, as far as wounds, and eventually some infections and maybe amputations, worst case scenario. So we can use the movement analysis to really kind of support some of those. And again, correcting some abnormalities in their ground contact is extremely important anyway, especially if they do have peripheral neuropathy and they're at risk of wounds and falls, because correcting those things can be very beneficial. I don't have a follow-up on this guy in this system either, but I'm working on something that hopefully is going to look pretty cool in that next month that we're going to talk about. So not really a part two to peripheral neuropathy, but kind of a continuation, but gets into something else that's, I think, very interesting, and something that we've been working on over the past several months, which is I'm excited, and it's super cool. So I think we've got a time for some questions. Yep, it's 1:49. Well, 1:49 my time. It's a little bit later your time, depending on where you're from, or it's earlier, I guess, if you're over on the West Coast. So I will. So in the chat over on the lower right-hand side, if you want to ask any questions, then you can just type those in there, and I can actually see them, as is Rana.
And in the meantime, I'm just gonna post a link for a very small evaluation form, very brief. It will take you less than 2 minutes to fill it in. It would give us more insight concerning the webinars, what topics you'd like to see more, and if you have any specific feedback. So I'm just gonna put the link in the chat here. Please just click on the link. It will take you just a couple of minutes. Thank you so much. And if you are interested in getting a certificate of attendance, please also email me. I will put my email as well.
Yep. So again, a reminder that this is a monthly reoccurring. It's really kind of about, getting people as comfortable as they can reading the analysis. So we choose different topics. This one was a use case that obviously highlights walking. We also do running as well as the jumping, and there's a video section of the app as well. So look out for this every month. So we try and do this on was it the third Tuesday of the month, Rana? I think it might be.
Yes.
So
Yeah.
I wrote it
The
down
next one
someplace.
would be on June 17 as
Yes, okay. And I think I saw you post that. Um, let's see. So Ramsey, hey there. How is the software progressing with being able to identify gait, such as cerebral palsy? Um, so, and that's actually one of the things that we've been working on. And so we've got some new scientists that have joined our amazing team here as well. And so we just presented on a couple things in the neurodegenerative space, and it's very promising and super cool. So we're actually going to be making some potential options, or it could be a different standalone product in the future, but it's the same technology, and it's actually progressing really well. We also have, I think Giannis is
Yeah.
there too.
Can you
So
hear me?
Giannis is, yes, we
yes,
can.
we can.
So
Okay.
Giannis is actually the head of product development, and so he's all over this. But I can say I've seen some really amazing stuff that never would have thought of that, even 5 years ago.
Yeah. So just to give a to give a more thank you very much, Chris, for the presentation, and thank you
How
all.
much is propulsion ratio dependent on the movement of the speed of the opposite swinging limb rather than the hip flexion on the positive side? Um, it's my understanding, and Giannis can correct me, that uh, I don't believe that is part of the calculation. And so ours is looking at the velocity from that toe off phase, and that is related to the angulation, and that impacts sort of the prediction model of hip
Yeah.
flexion as well as foot. Whereas, and so there's more than one way to calculate a propulsion rate or propulsion ratio, depending on, people still decide what exactly they want. But it's my
Yeah.
understanding that it does not have any impact on the or
No, because we
inclusion of the
measure
opposite
each.
side.
Yeah, we measure the proportion ratio of each side independently.
Yep.
Um, and so far we haven't seen really an impact on the opposite side for each piece. So, but yeah, we consider like the propulsion phase, uh, and then the swing phase on each side on an in an independent way. So far we haven't seen any like noticeable impact from each side to the other. I think we're almost done. So obviously, if there are any more questions, don't hesitate to send us emails, contact us. And yeah, as Anna wrote here, thank you very much for your participation and your time. And yeah, we're happy to share all our thoughts and the great work that we've been doing in the last few years. And thank you very much for Chris' time and analysis. So thank you guys. Have
Rock
a
and
good
roll.
rest of the
Thank you.
day, evening,
Yes.
night,
Thank you
Thank you,
all.
Casey.
wherever you
So
are.
come back. Come back. Don't
Yeah.
forget. Come back. Come
Yeah,
back.
come back next time. And again, if you have any ideas, please suggest if you have any ideas or topics that you would like to see for the upcoming webinar. Please don't hesitate to suggest. Give us your thoughts. We'll be happy to answer.
I've
Yeah.
included
And
my email in the chat. I'm just gonna put it again, so like
Yes.
you could reach me, and if you want to reach Chris, also this is a shared email, so everybody, I mean the education email, everybody can have access to it. So we'll be
Yes.
gladly be there for you.
All right. Thank you
awesome.
very much,
We look forward to
guys.
more.
Thank you.
Thank you.
Till next time. Bye.
Ciao.
Bye.